shaky foundation, eventually you're going to be compelled to pull down the entire thing, have a foundation, and build a new house. It have cost us about 100 times the amount of money. So we're looking at revenue. What we do where I work, and I want to make this practical, we have the financial, we have these four, and basically there's a CEO. So we all do the work of the CEO. So the CEO has his KPIs, and he must deliver on these four. So everybody, whether or not they make money, whether or not their work involves making money, what you call a cost center or a profit center. So for example, pharmacy, medicine, surgery, wards, ER, they all make money. The cleaners do not make money. Accounts do not make money. Internal audit does not make money. But internal audit, for example, helps us to save money. They have audit systems in place, internal controls, checks and balances, so they help us to save money. So indirectly, they contribute to the revenue and they contribute to the profit margin. So we have systems to be able to determine the extent to which everybody is directly or indirectly contributing to the revenue of the business. So our 5 main things are revenue, our cost of sales. We have a mandate to keep our cost of sales do not exceed a particular level, a particular proportion of the revenue. Otherwise, we cannot be making money. But I'm spending we're making $1 million, for example. One person is spending 800,000, another person is spending 200,000. And they say, how many people are making $1 million? We all put up our hands. But then now keep quiet when they say, what is your cost of sales for your operating expenses? We are no longer on the same level. So we look at profit margin, cost savings. Cost savings in Nigeria is equivalent to cost cutting, and cost savings is not cost cutting. Basically looking at ways by which we can save, putting out electricity as soon as we don't leave a room, things like that, trying to marginalize or minimize the opportunities for wastage in any form. Instead of walking up to a building, you can pick up the intercom. We have a call policy in our communications. You don't go to an office, you always call first. And the thing is called call first. Call first to ensure that the person you want to meet is there, and the resources you want to go and collect are available, ready, and waiting. You don't just walk on people's offices and just show your face anyhow, and then until you come back, they're not sure that the person is there or not, things like that. So we have what they call fragile innovations. For example, at some point we looked at all our forms. We felt we had too many forms. We reduced them by almost 25%. We combined like 4 forms, became 1 form. 1 form we decided we didn't need that form again. We turned somewhere else. Some forms we discontinued them, replaced them with plastic tags. So the tags are recyclable. Instead of getting paper and wasting paper and storing them in the space. But many of the forms have to be scanned, and they have to be audited by the auditors. So internal processes, like I mentioned before, corporate governance, clinical audit. We not only audit, the patient records are audited daily, consultants are paired horizontally, they're also paired vertically with medical officers under them. So everybody checks their own work as a self-audit, and then they have health information management staff, they audit documents. In the non-clinical areas, documents must be audited weekly. And at the end of the week, they will say, for example, we've audited 50 documents. Of the 50, there were no entries, no dates entered in 15. Some of them did not have titles. These ones were not signed. So all those things are there every week. And there must be a quality improvement process to make sure that that does not happen subsequently, or at least the frequency of recurrence is minimized. Customer satisfaction, we do 4 things. We have inpatient experience, we evaluate our doctors, service quality evaluation, and we have what we call the Net Promoter Score. We just ask 1 quick question. Would you refer us or would you not refer us? If you would, why? If you would not, why? And that is one of the things we look at. So we try to use that as a basis of improving our services. Learning and growth. All staff are required to attend. We have a list of mandatory trainings, and staff can find when they need to do them. They have a time frame within which to attend the internal ones. Some of them are online, some of them are on our internal portal. And all these things contribute to the performance appraisal at the end of, I think it's on the report. So systems, the process approach. The system consists of a process. The system is basically how things are arranged to happen. You have subsystems that we mentioned, have microsystems. So a hospital is a kind of microsystem. Within a hospital, it becomes a macro system comprising of many microsystems. So for the process approach, it's very simple. Taken away from the hospital environment, everybody at some point in time is either a customer, a processor, or a supplier. So basically what happens is that we all have something that we are processing. We receive it from somebody or someplace. We have to do something to it. We have to improve it, either by recording, by documenting, by treating a patient, by processing a prescription, by filling a prescription, by labeling a document, by cleaning a floor, by washing a mop, whatever it is, and we pass on the product or the outcome of the service to the customer. So there's also something called supplier, input, process, output, and the customer. Why do we have a system or a process? If we suffer efficiency and effectiveness, the customer must be satisfied, not once in a while, not occasionally, but every time. So based on this principle, every organization has only one objective. Based on that objective, we have different departments that are designed or created. Every department has only one objective. Based on that, there are many processes that have to be performed. Every process has only one objective. So, every process has only one objective. For everybody performing the process must know their customer. We tend to look at patients as our customers. Patients, visitors, contractors, clients, and our fellow staff, our colleagues, have internal customers. And really, our internal customers are more important than our external customers. And the context is, we mentioned before, finance, internal process, customer satisfaction, learning and growth. If we do not treat ourselves right, by extension, it's almost impossible to treat our clients right. But I guess psychologically we tend to do that because remember that not treating them right may actually affect our pocket, and I think that is the the single most important motivator for doing right. But we have seen places and instances where staff insult patients and respond when they don't need to respond, things like that. But basically, these are the key things. We must know who the customer is for documentation. Every single question there, the answer has to do with information, data, and or documentation. So this takes us back to data imperatives. If we can get our data right, at least we can guarantee that 75% of our systems will be effective and efficient. So key information is shared based on data. So to save the PharmAccess, by the way, my hospital is actually embarking on the COSASA journey. The learning curve is very, very steep, and it's very steep, I stand here to say, because we lack the attitude and the discipline, the level of discipline required to sustain the work, because it's a different type of work. Everything we do must be documented. But I've been giving the patient the job, that's why they're getting better. But there's no evidence I've been giving them medication. Those are the kind of things that make a system effective or not. So measures must measure what is meaningful and what matters. We can't just measure for the sake of measuring. So we have lots of data. People tell me they are pushed off documenting or providing data because they're always showing you data. You kind of write so many reports, nobody reads them, they gather dust, nothing happens to them. So people are basically discouraged from documentation or data input or basically even making reports. So, however, we don't have a choice. The way what has been done, what they call the minimum data set. Minimum data set, there are some things. We have data for decision making. We have regulatory requirements and statutory requirements, professional requirements. We have operational data, and we also have the outcome, the work we are doing. How well is the work we are doing? And we must be the ones to measure ourselves. But we normally wait for other people to come and tell us how well we have done. So we need to have our own matrix for determining how well we have done. So basically, these are just the things that the attributes for any measures. If I can be told how many minutes I have left. So measures can either be single item or composite. I just take examples for them. So Very important. This at the macro level, we need to understand what we are doing. Many times people are just working and they say, oh, I don't know how many patients we saw today. Well, somebody has given the list to the head of the department, and I find that very interesting. We are seeing patients, we have no idea how many patients we have on the ward, because somebody else comes around to take the head count, as they say. But now, everybody should know how many patients they have seen, what kind of things they have done for the patient, the status of the patient. So productivity is not just numbers, frequencies. We must know outliers, exceptions, deranged values, anything out of the ordinary. Why did they happen? More importantly, and what can we do to make sure that they don't happen as frequent? Time and motion, we don't have regard. We have minimum regard in the healthcare industry. We have very minimum regard for our time and for our motion. And that is very important because it also affects the quality of care and our health outcomes. So our performance, profitability, clinical effectiveness, patient safety, really about HAIs, hospital-acquired infections. I would like to add malaria, because in many hospitals in Nigeria, patients come. By the time they're leaving, almost more than half of them have to go with malaria. So I think we make it HAIN instead of HAI. And then we have operational efficiency. We don't tend to measure these things because half the time I'm being paid, I'm being given a salary. People are beginning to change the way they pay. So they pay the basic salary and they pay for performance. So the performance targets and performance targets, not just numbers, as in how many patients we have seen, but for the patients that we saw, how many of those did we do what was required to be done? So we are measured by that. So there's a base salary and there's a percentage incentive. So there's a motivation to do the right thing. That's not the best way to do it, but at least so far we found that it works. So customer satisfaction is very important. It's very subjective. So usually we don't give it a very high value. And the reason is that patients come in at different states of consciousness. They're very ill. Pain management is a key factor. It obfuscates everything that is being done. As patients start to get better, they will complain about the meals, about the television. So, but basically the thing is the images, we take those and we know what we have to look at to ensure that they are actually reliable and valid complaints. We also have things like mystery patients, who are people who are auditors, and we let them come in to go through different departments in the hospital, and they have a checklist, and they actually determine whether or not our processes there's fidelity in the system. I'm just going to flash through. These are the kind of things that we look at. Matrix must have, every department must have a list of planned improvements. What initiative or intervention? We do this every quarter. At the end of the quarter, we have got 5 or 6 planned improvements. How many were you able to achieve out of those 5 or 6? We have a code, something called the Pareto curve. The Pareto chart can help us to determine and prioritize what is important, what has the highest impact, what has the least cost, and what has the widest reach. So we can do that in every department. And at the macro level, the CEO, executive management, or the CMD or the MD can do that with the consultants. So it's initiative, quality improvements, process improvements, resource management, safety or risk factors, incidents, adverse events, never events, sentinel events. We have a culture of silence in our hospitals. Many things go wrong and nobody says anything. But one fine day, something goes horribly wrong. Then we now start to refer to all the previous occasions where the same thing has happened. I think I'm the only one who sees all these things. Nobody else does. And then of course we have customer satisfaction. So another thing it's good to do is SWOT analysis of the hospital itself and of every department. What are you strong at doing? So for departments in the hospital, it's going to be comparing other departments on common things. What is our strength? What is our weakness? What are the opportunities for improvement, for growth, for expansion? Even the hospitals can begin to look at that. And what it does when we sit down in teams and do that, it helps us to think out of the box and determine innovative ways. So the government will tell us we don't have money for this. If we gather together and we huddle, we can find an alternative to the government. Let them hold their money. We try to see another way how we can make sure this happens, with or without their money. So this is just things we need to do, weight and mentioned before, daily, weekly, monthly. So all these are macro level. But the extent to which these things can work, like I said, is based on what has been made available. Policies, regulations, and all those other things at the macro level. So system matrix, these are just examples of the kind of things that can be measured at the macro level and measured at the micro level. So now we're getting to cost. In cost, I'd like to say two things. Healthcare is a negative, they call it the industry of healthcare, is a negative demand. Nobody wants to go to the hospital, not even for a checkup. And studies have shown social science, annals of social science and medicine, the only time people was a global study in different countries, well, 180-something countries. The only time people wanted to go to the hospital was either to go and have a baby or to go and see somebody who just had a baby. Otherwise, there's a general reluctance. It's like fully quoted drugs that wait for an examination. They don't quite sure what the results are going to be. So it's not a function necessarily of being educated or having money. We just go because we must go, so we don't really want to go. And the second level is that when it comes to the payment, everything, there's nothing called free health. Everything is paid for. Either paid for prepaid, paid for the time, or paid for the future. We are the threshold now that we can say, it's very interesting to see how this pans out. It's interesting to see how this pans out. But basically, what we need to look at, and we don't look at, apart from utilities, rent, and salary, I want to mention a few things at the micro level. This is where it takes us. There's something called sunk cost and opportunity cost. And I'll just use two simple examples. An example would be, for example, let's say expired drugs. Where I work, we look at the value of expired drugs, the frequency, and the quantity. We also do the same thing for stockouts. Why do we do that? For expired drugs, it's a sunk cost. So the drugs have been purchased. If they had been dispensed to patients, we have made more money, we have made a profit. But we've lost the cost, we've also lost the opportunity to make extra money. Stockouts, we never had a drug in the first instance. So we're not able to prescribe them in the first instance, so we have to go somewhere else. So there are similar parameters that we can draw. And we can begin to look at this and own the business, and we own the business for those of us who actually own businesses and are not covered by the government challenges and the government framework. We can begin to look at managing our costs from some cost and opportunity costs, trying to minimize them and then transfer that to our revenue. So these are things that we have in care quality. I mention this because it's common to everybody, but underlying these are people we do not see. You don't see the cleaning, you don't see the cleaners, you don't see the auditors, you don't see the laundry and linen. We have, for example, we have linen delivery, daily linen collection, linen delivery. If they are defective linen, how many are defective? What is the cost? Is it because it's torn, it's faded, it's worn, it's bleached out? So we have all those things even at the micro level, very important. The patient can decide not to be admitted just because the bed sheet is not clean enough. So what have we done? We've lost the patient. It's tried against medical advice. If they spend the number of days they ought to have spent on my bed, I have made more money. So these are just examples of the kind of things that we should be looking at that will help us in decision making. Process improvement basically is looking at the process itself, trying to purify the process, minimize the number of steps. There's something called hazard analysis and critical control points. And I use the example of making jollof rice. If I can make stew, if I can make jollof rice, most likely I can make stew. However, if I can boil rice, there's no guarantee I can make jollof rice. If I can make stew, and then I can blend the pepper, the onions, and the tomato. So it's looking at the process. Everybody needs to know where the process begins, where the process ends. What is my process? But we have lots of redundancies and omissions. People are doing the same thing, but they're doing it differently. So our work is not standardized. So all these things are in process improvement. Error-proofing the process, purifying it, constantly looking at it to see how we can further reduce the number of steps required to achieve. We save time, we save money, we save resources. Quality improvement is looking at the outcomes, how the outcomes can be better. Process is looking at how we work, the way the thing is actually done, why this is being done. Quality assurance is after it has been done, let me count what is happening, when it's happening. So basically, overstay my time. 3 things. Cost considerations. Globally affects everybody. Costs are escalating. The cost of everything, we need to look at that, because that is a common factor all around the world. Value-based purchasing is something that happens abroad. At some point, somebody mentioned just in time, one of the previous presentations, and I remember we had a discussion at one point trying to peg down the value of our expired drugs. I think it should be 2%. So we were saying, how do we do just in time? I said it's impossible to do just in time in Nigeria, because many things are dependent on the supplier. Sometimes certain things are not available in the market, and then you have many layers of people who are between what we are getting. They are the ones who actually control the availability in the manufacturer. So when you look at things like that, it's actually a compounded situation. So you have to begin to look at innovative ways. And what I believe is that we're talking about is value creation is very important. The patient or our clients must perceive the value we claim in order for them to pay for the service. If I tell you my service is 100,000 naira, there must be some perception. As I'm coming in, I'm seeing 100,000 naira. I can imagine that I'm going to be told to pay between 80 and 120. So if I'm told to pay 800, then I don't feel too bad. But if I'm coming in and as I'm looking, I can't even see anything close to that, then there's a serious problem. So basically, all these costs are outlined and they're very important to look at. I think I'll just have to stop here. The only thing I want to mention is that we have to look at something called contribution margin. It's very important, and I'm ending. We look at fixed costs, and when I look at fixed costs, these are things that do not change regardless of whether patients comes or not. And what we tend to do is that we now jack up the prices or the cost of care. So there are 2 things. There is cost of care. The cost of care is like a fixed cost. Everything we make available for us to provide care or services. But the cost to care is what happens at the different times or different points in time that our patients come. So if I see that, oh, for the past 2 or 3 days I've not had too many patients, I'll try to make sure that I do what we call unnecessary treatment, or just add some extra things so we can make some extra money. I'm not saying we do that, but remember we had mentioned things like ethics. So when we look at our cost of care, ideally, our contribution margin is what makes up our fixed cost. So if we have criteria, if we look at our system, we have guidelines, for example. The guidelines determine the fact that every doctor sees every patient with the same condition in the same way, going through the same sequence. Our guidelines, for example, would inform our drug formulary. We have a system that says this is when we use generic drugs, this is when we use branded drugs. We know which items are capitated, we know which ones are fit for service, and we all have there's a fidelity, but there's a faithfulness to what we have written. We would really be able to contain our costs. We've actually seen it, because our patients see through the variations in our system. And when they see through the variations, the next time they don't come, we don't see them. But apparently they come to the next doctor or the next hospital next door. I've overspent my time, and I'm just going to leave this with people to hopefully read through and make sense of. Thank you very much.
Dr. Nika, okay, we'll be going straight to health financing. This is a very important topic for all of us. Health financing in Nigeria, prospects and challenges with health financing. And to take us through this workshop, we'll be calling on Dr. Olamide Okulaja. Dr. Olamide Okulaja is a health financial specialist with Health in Africa Initiative, IFC, that's International Finance Corporation, World Bank Group. Let's put our hands together for him as he comes up.
Good afternoon, everyone. Obviously, I think my voice is louder than most, so yes, no problem. First of all, I want to say it's indeed a huge pleasure and it's a humbling experience to be talking to you today. I see a lot of my seniors in the room, and so I defer to you today and I say thank you for coming for this workshop. I'm very sure you know a lot more than me, but I just want to reiterate a lot of things I want to, that I'm going to say today. Once I'm talking about healthcare finance, people are asking me how much money I do to give. But unfortunately, that's not what I do. I don't have any money in my pocket. In fact, I'm one of the poorest units in the World Bank, and we don't have any money to give. But one of the things that we try to look at is to see how people can access finance to provide healthcare. So, I was going to cram this so that I can impress you. It's good to cram and impress people. Then you read out numbers and quotes, but it was too long. WHO defined it that when of the people individually and collectively in a healthcare system. The purpose of health financing is to make funding available as well as to set the right incentives, financial incentives to providers to ensure that all individuals have access to effective public health and personal health. That's the definition of healthcare financing. Did anybody say then that it's a process of giving anybody money? It's not. So please let's dissuade our mind from that. And I need you to please listen, because you see, if you did not learn anything today, you have to learn something. How are you going to make money? And how are you going to key into the prospects and systems that are building right around you to be able to remain sustainable and provide quality healthcare? How do we sort out the demand-side financing issues we have in Nigeria? The World Bank did a study recently, and they called it Principles of Good Healthcare Financing. And they said, well, they did a study of low to middle income countries, about between 8 to 12 of them. And they said, there is no right model for providing healthcare financing for a country. However, there are some things you need to consider for a country to achieve universal healthcare coverage. And one of the things I want us to believe, because I'm a strong proponent of universal healthcare coverage, I do not believe in a situation where we provide finances to providers and we are not aiming at covering everybody in a country. And they said for universal healthcare coverage to happen, there are three main factors you need to consider. One, you need to consider the economic and institutional factors. You need to consider the policy factors and the implementation factors. When you talk about the economic factors, you say for a country to aim at achieving universal healthcare coverage, it has to have a strong economic growth. There also has to be political will. There has to be institutions that are set up that would, adopt policy reforms, and also a people that are educated. Very important, because if the people are not educated, then there is no way you can talk about healthcare financing. Because healthcare financing is not about buying and selling. It's about mobilization and allocation of funds. When you talk about the policy factors, it talks about a strong financial commitment towards providing resources for healthcare by government. It talks about equity. It talks about social solidarity. It talks about consolidation of a risk pool and a recognized limit to decentralization with a focus on primary health care. And I'm saying all of this, and you would see why everything I'm saying is important, because it feeds on what we are going to discuss when we talk about health financing in Nigeria. The last thing I'm going to talk about are implementation factors concerning the factors that you need to consider in implementing universal healthcare coverage. One, there must be a sequential delivery of healthcare systems. That means it must go from primary, secondary, to tertiary. The problems that we have here in this country is that we have universities that are providing primary healthcare services. And so it stifles the primary healthcare delivery system. There must be a sequence in that happening. There must also be provider payment reforms. So the way that providers are being paid right now, there has to be a reform. We have to look at it. We have to bring a strong stakeholder engagement. Anyway, let's go on. What we want to achieve. Is anybody familiar with this box? Is anybody in this room familiar with this box? That box is the universal healthcare coverage box. And it was designed to look at how we can provide universal healthcare coverage in a country. It's looking at three indices: the services that are delivered, the population that is covered, and the reduction in the financial hardship for people to access healthcare. Now, this is what we want to be able to achieve at some point in time. And if you look at that little box in the big box, it's saying that we don't have to achieve the whole thing, but we have to look at a balance in these three things and see how all parties benefit from providing universal healthcare coverage. If we look at UNC in Africa, we have a high out-of-pocket payment system, greater than 90%. You understand this? The out-of-pocket payment system in Africa is greater than 90%. That means that 90% of people in Africa pay for healthcare out of their pocket. In a society where 70% of the population live on less than $1 a day. Do you understand that? So you are living in a society that lives on less than $1 a day, and 90% of those people are paying for healthcare out of their pocket. What's going to happen? If we continue this way, you will not drive a Porsche. You will not drive an Escalade. You will continue driving the cars that you are driving. You will, because people that you are catering to cannot afford to pay for healthcare services. And so, what happens? There are constraints to healthcare seeking behavior. So they go to different people, apart from the people in this room, to see how they can access healthcare. They go to the pharmacies, they go to the TBAs, they go to different people. And then when they get complicated and they cannot pay for healthcare, they come to you and say, "You have my experience, and you have to help me." And that's the problem. When we also look at the government expenditure, the battery is going down. And you look at the second box, you see that Nigeria is part of the countries that is contributing or allocating between 3 to 5% of its GDP to healthcare. 3 to 5%. About 80% of that allocation is used to pay for the salaries of tertiary institutions. The remaining 20% for the other things. No money for infrastructural development, no money for training, no money for anything. And this is across a country of a population of 200 million people. Now, Sub-Saharan Africa accounts for 11% of the world's population, yet it bears 24% of the disease burden in the whole world. Our economy is improving. What does that mean? It means that if our economy is improving, then we have more people that are able to work and contribute to the GDP, which means that there are more people that can contribute to paying for healthcare. And so, McKinsey says that over the next decade, you are going to require about 25 to 30 billion naira in new investments to cater for this growing population. Where is this investment going to come from? Of the total health expenditure, 16.7 billion, approximately 60%, predominantly out-of-pocket payment by individual, was financed by private parties, and about 50% were captured by private providers. So what this is telling you is that 50% of the providers cater to all the healthcare needs. People access healthcare from private providers. The private provider is too large to be ignored by government. So one of the things that government needs to do is to begin to see how they can adopt the private providers, to adopt them to see how they can begin to provide quality healthcare. But if you look at the distribution of that 50%, you will see that the for-profit majority of people in this room account for just about 65. Then you have the social enterprises, which is about 15, non-profit 10%, and traditional dealers about 10%. Now, if you look at this diagram just basically look at the vicious cycle of healthcare delivery systems in Africa. I always take my presentation in a funnel approach, so please bear with me if I'm not yet talked about Nigeria. You will hear about Nigeria. It's a sad situation, but we all need to hear about it and see how we can all come together and improve the health outcomes of Nigeria. So basically, health systems in Africa are caught in a vicious cycle between a lack of demand and supply, where you have private and public investors suffering from a lack of regulatory framework for functioning institutions, stifled investing with high risk and high transaction costs, and public money resulting in unintended crowding out effects. What do you mean by public, unintended crowding effects? If government is going to do an MPC program now, those people in the public facility just beside you, overcrowded, poor quality of healthcare, and you are sitting down there reading newspaper, no one. What happens to you? You have been crowded out, even though you are able to provide quality services. If you look at the payers, it's secure and opaque markets with high risk and high cost and limited client base, insufficient quality of care delivery and enforceability of regulatory issues, poor quality oversight. You look at the providers have low quality of services, poor management, lacks efficiency, lack standards of poor regulation, and lack of access to capital. That is the main problem that we have. We don't have money. And then the patients, limited awareness and demand, no prepayment, catastrophic out-of-payment systems, low trust in the system. In formal sector, patients rely on word of mouth when choosing services. So you see this diagram. This diagram depicts a market failure, total market failure that is not reliant on the laws of demand and supply. And so, we have the graphs that suffers. But basically, this is what we are hoping to achieve. There's a need to create virtuous cycle towards system transformation through PPPs. So one of the things I'm going to tell you here is that as private providers, there's a need to begin to see the opportunities that are abounding from public funding and see how you can deliver those services. And those opportunities are coming up day by day. And we'll discuss some of them. How has the government tried to mobilize financing for healthcare? One, they try to improve efficiency in collection. So hopefully, by improving, when you go around Lagos now, you pay your tax. As you pay your tax, hopefully the allocation, the percentage of health increases, and then they're able to raise financing for healthcare. But we've not seen that happen. You have efficiency with healthcare expenditure. Has anybody heard about the Basic Healthcare Provision Fund, the National Health Act? We'll talk about that briefly. Talk about innovative taxation. So one of the things that governments are looking at is how can you tell me that for every phone call you make, they take 2 kobo equity like that to healthcare finance. So these are various ways that governments are trying to see how they can improve financing. But what is more important to me, well, the last thing here is that I want to talk about is leveraging on the private sector. How? Optimizing healthcare through the private sector. There are different things that can happen here. If you look at health infrastructure, Africa will need about $30 billion to close the infrastructure deficit. In light of building government expenditure on healthcare, it is imperative that the private sector gets involved in closing the gap. The private sector can help manage public infrastructure through public-private partnerships. And that's what we need to start looking at. It is not good enough for you to sit down in the city and look for funding to improve your business. You need to start looking at how you can generate sustainable income for your facilities. Also, quality healthcare provision. I'm going to be fast because I don't have a lot of time. Access to health, monitoring, and facilities and human resources. So basically, what challenges does the private sector face in providing quality healthcare service? The first is that there is poor healthcare service. So the government don't trust the private sector because they feel that the healthcare delivery system is very poor. The is highly fragmented and atomized. So you can find one private facility there with one bed. Just beside it, you find another one with 2 beds, another one no bed for the other outpatient, and very fragmented. So it's very difficult for government to be able to conduct business with these people. There's poor quality oversight, and there's lack of financial and technical support needed to strengthen the ability of the public and private military bodies to develop and enforce transparent and effective quality standards. The most important one to me is that there's a lack of a risk-free lens, because the only way that we can effectively pay for healthcare is through a risk-free lens, especially in a country where majority are poor. Inadequate mobilization of public and donor money to the private sector, implementation of policies that promote PPPs, and lack of adequate access to capital, which I am sure that will be handled in the next presentation. So what are the prospects? Now, going to Nigeria, I want us to look at these statistics. I don't know how many people in this room know these statistics, but let's just go over them quickly. About 900,000 children and mothers die each year. Child mortality is 109 out of 1,000 live births. Maternal mortality is 550. I saw it somewhere yesterday night that it's 557. It's around this number, about 100,000 live births. Nigeria contributes 14% of all maternal deaths globally, only second to India. So we're the number 2 in doing that. Nigeria also accounts for 13% of all under 5 deaths globally, only second to India. So we're very successful in doing things like that. Very successful. Nearly 1 in every 5 children are at risk of dying before their 5th birthday, and 1 out of every 9 pregnancies will result to death. That is Nigeria. That is Nigeria. If you look at the number of doctors that we have in Nigeria right now, you have, according to the register, about 40,000 doctors for a population of 200 million people. 50% of those 40,000 doctors are here in Lagos State. So you have 20%. And Lagos State has a population of what? 23 million. So you have 20,000 doctors for 200 minus 23 million. And we do not expect these things to happen. Of course it will happen. It has to. So there's a need for us to begin to think, not just as doctors, but as a country, in providing solutions to our problems. We need to start considering things that we're not previously considering, like tax shifting, like seeing how we can partner with the government, to see how we can do this. Because collectively, then we can improve our circumstances together. Let's look at what the NHIS is doing. Initially, the NHIS was a big body, centralized. 2005, everybody knows the story, 3% of coverage, nothing happened for 10 years. You know, I'm not going to go into that. But going forward, one of the things that NHIS has tried to do is to propose a model with states to see how states can begin to provide health financing systems for their indigents. And so they propose this model. This model says that NHIS should be in charge of UHC fund, revenue collection. So basically they would accumulate money through different mechanisms. And with this money, they will assist states in fund pooling. So you can see that each state now begins to pool funds on its own. And then they become purchasers of services from both public and private hospitals. What is the importance of that to everybody in the industry? What's the importance of that? The reason why this is important is because states and the NHIS are moving towards what we refer to as mandatory healthcare insurance programs, where everybody will be required to contribute to a pool. And if everybody is required to contribute to a pool, the fund that is put together is then used to purchase services from both private and public providers. So imagine a population of Lagos State, 23 million people, contributing at least 5,000 naira. Are we saying that that is not enough to provide quality healthcare service, or enough for us in this room and everywhere else to spend to provide healthcare services? That is enough. And this is a good start. But what is more interesting is that states such as Lagos State that have succeeded in passing their law and is going to implement mandatory healthcare insurance before the end of the year, have also allocated 1% of their consolidated revenue fund in providing payment for the poor and vulnerable. So there is a lot of money that will be available in the demand for healthcare. The problem for me is that as we provide this demand for healthcare, how are we going to provide this healthcare? Are we as providers, private or public, ready to absorb all of these monies that are coming in? So the revenue mobilization is a state mobilize domestic resources for coverage, NHI mobilizes UHC fund centrally, UHC fund allocated to state pools using agreed criteria. Pooling and purchasing. Pooling and purchasing functions done at the state level. Purchasing can be direct or through third party. Service delivery, healthcare to be delivered at two levels, primary and secondary. NHIs and states negotiate fees payable to healthcare providers. So, that scenario where a public facility is providing services and a private facility is sitting beside it, not providing services, is going to be eradicated through this. There is going to be an opportunity, equal opportunity between private and public providers to deliver quality healthcare services. But one of the things we need to understand is that states like Lagos State, Delta State, Ogun State, and about 16 other states that are in the process of passing their mandatory health insurance schemes would have an accreditation system that needs to be put in place. That means you cannot just say, hey, I have a facility, assign patients to me. You have to be certified to be able to provide quality healthcare service. The Basic Healthcare Provision Fund is a fund that is put into power of play by the National Health Act. And basically what happens is that through this act, the federal government committed to providing 1% of its considered revenue fund to healthcare services. And that will be delivered through 3 gateways. And this is what this diagram is trying to explain. So the Basic Healthcare Provision Fund will be funded by different means. 1, the 1% coming from the government, 2, donor funding, and 3, any other person that wants to contribute. But I guess that the most important one is this 1%. And it's going to go through 3 gateways. Through the National Primary Healthcare Development Board agency, through the National Health Insurance Scheme, and through the Federal Ministry of Health, in a ratio of 45, 50, and 5% respectively. So through the NHIS, the federal government is going to purchase a benefit package that will be delivered at HCPs, private and public, directly. And so the fund manager or the fund holder is going to be the CBN. And once you can go through an accreditation system, once you are able to show that you can deliver quality services, you will register with your TPA or the state-supported health insurance scheme that will then provide your account number to the central bank, and every month as you see patients, you get funded. Now, one of the things they've done is that they have looked at strategic purchasing, and they are now looking at a situation where results are not based on input but on output. So basically, it's going to be based on the number of pregnancies you have delivered, or the number of malaria you have treated, and all of that. If you are able to do that, then you will get directly paid from the central bank, not HMO. That is one of the things that the federal government has just put into play. And this guideline has just been approved at the last National Council of Health. And so it's budgeted for. Now, what is happening? There's a lot of money that is coming. there's a lot of money that is going to come to private providers. But if you are unable to show yourself worthy enough to provide these services, then you are not going to be part of this whole thing. Now, if you look at the Basic Healthcare Provision Fund, it was established through the National Health Act, funded by 1% of the government, recently approved at the emergency NCA that was held a few weeks ago. 3 gateways: NHIS, MPHCDA, Emergency Medical Gateway. And the NHIS gateway utilizes both public and private providers.